This is our July sort of episode of our NF Knowledge series, which is CTF's monthly educational webinar designed for patients and families that are living with NF. So, as I said, I am Kate and I will be your host. I'm very pleased to welcome today Dr. Sanjay Aneja and Dr. Frank Buono. Dr. Aneja is a radiation oncologist and assistant professor at the Yale School of Medicine with appointments in therapeutic radiology, biomedical engineering, and bioinformatics. He directs bioinformatics and clinical data science at Yale's Cancer Center. Dr. Aneja's research applies machine learning to diagnostic imaging and treatment personalization for cancer, especially central nervous system tumors. He also serves on national committees advancing digital health in oncology. He'll be joined today by Dr. Frank Buono, who is a research scientist in psychiatry and orthopedics at Yale School of Medicine and the co-director of the Neurocutaneous Clinic at Yale New Haven Hospital. Dr. Buono's research focuses on digital health tools for individuals with rare diseases, including NF. Dr. Buono led the development of the I Can Cope NF, a pain management app for NF1, and recently developed AI software to enhance the accuracy and speed of NF tumor evaluations. So that was a lot. They're also obviously both really brilliant guys. And I have to say, I've heard some of this presentation before, and I'm very excited for everyone to get a chance. Because if you're like me and AI and machine learning seems like something you would never be able to understand, I can assure you they're going to do a great job welcoming you all to the wonderful world of this kind of technology. So I'm going to go ahead and spotlight you, Dr. Aneja, and let you take it away.
Perfect. Thanks so much. And I'll share my screen so everyone can see my slides. Perfect. So thanks so much for everyone for joining today, and thanks for the opportunity to speak about a topic that obviously is near and dear to my heart, which is specifically AI. Frank and I have collaborated now for about a year, a little more than a year now, and I've learned so much about the NF community and having to meet with both researchers as well as some patient advocates, et cetera, in the community. It's a really great opportunity, I think, to specifically leverage sort of the advances in artificial intelligence in this group. All righty. So here are my disclosures. And so in terms of an agenda for what I'll be talking about, I'll give a little bit of background about our lab, the work that we do, and sort of and how we kind of view machine learning. The second thing is that I will provide everyone a little bit of a background about sort of comparing AI versus machine learning versus deep learning and trying to sort of level set everyone's understanding and vocab. And then we'll also talk a little bit about some practical machine learning and deep learning, and we'll talk a little bit about sort of how these models actually work. And then lastly, I'll turn towards some of the AI success stories. Primarily, we'll focus, our lab primarily focuses on the imaging space, but there's also these sort of success stories on the non-imaging space that I'll also talk about. And those are more broadly in the cancer sort of realm, but I think that they can very easily be applied to NF or NF-like problems in the future. And then lastly, although we're very positive on artificial intelligence and things of that nature, I think that there's certainly some barriers to AI implementation, and we'll talk a little bit about that. So then we can understand sort of where we still need to sort of progress in order to be, achieving our goals and sort of making our healthcare system a lot more smart. And so I'm very fortunate to be a PI for a very multidisciplinary group of clinicians, data scientists, computer scientists, engineers, and mathematicians. Our group is primarily interested in kind of three research areas: machine learning, algorithm development, data science theory, and then the clinical application of existing machine learning techniques. And so, one thing that I think is important is that we sort of think about, how do artificial intelligence, machine learning, and deep learning differ? Those words are oftentimes used interchangeably whenever we discuss AI and healthcare and machine learning. And most of the time, it's actually okay to sort of use them somewhat interchangeably. But I think just to provide everyone a little bit of understanding, it's good to sort of break down what the differences are. And so first, when we think about artificial intelligence, it's the broadest category of sort of all of these programs or things. Artificial intelligence is essentially any situation in which we develop a computer program that is used to mimic human intelligence in any way, shape, or form, or any task that humans do. And so what we can see in the graphic here is Garry Kasparov. He's a chess grandmaster, and next to him is IBM Deep Blue. And this is kind of one of the first, at least, views of artificial intelligence that I sort of can remember back in 1996, where these team of IBM engineers essentially programmed within IBM Deep Blue all the different combinations of a potential sort of chess match. and they found that IBM Deep Blue was able to beat Garry Kasparov in chess. And so essentially, even if you just program every single possible combination, that can still be considered artificial intelligence. But understandably, it takes a lot of memory, because if we think about it, this huge computer only was able to do one task, which is play chess. It wasn't able to do the voice recognition or any of the things that we think of AI doing right now, no chat, GTP, et cetera. And so I think that the important thing to understand is that you can make an artificial intelligence algorithm where you define every little piece, and it's still considered to be AI because it's mimicking human intelligence. I think the first sort of renaissance that we thought about in the form of artificial intelligence was the development of machine learning algorithms. Machine learning algorithms are a little bit different than sort of like what we saw with IBM Deep Blue, because what they do is they essentially analyze the data and important features in that data. And using those important features, they are able to sort of develop a better understanding of data and develop a larger understanding that can answer a larger multitude of questions. And so an example of that is IBM Watson. When IBM Watson was on Jeopardy, it didn't necessarily get programmed every single question and answer that could be possibly given by the host. What instead it was given is a large amount of data from like text, mostly Wikipedia articles. And from that, they were able to extract keywords. And from those keywords, they taught Watson essentially how to find essentially what answers would be the most useful. And so this is an example of a significant amount of data was being used, but the algorithms were relatively helpful in determining what data was important in terms of finding the right answer. But it still required a significant amount of programming by the investigators who developed the program. And now the newest iteration is deep learning, and that I would say was the kind of the most recent advancement over the last 5 years. It seems as though it's not recent anymore because it's been around for 5 years. But if we think about artificial intelligence being around since the 1970s, then I think that we would say that this is probably a relatively new finding. The benefit of deep learning is essentially that instead of having programmers, sort of create algorithms that are defining important features within the data, like doing the word searches, like we saw with the IBM Watson. Deep learning algorithms essentially can take raw data streams and determine from those data streams what data is important, and sort of piece together all of the important pieces of data that are important in terms of solving a task. And the reason why that's beneficial is twofold. One is that it allows us to, instead of doing a very labor-intensive process of programming every little piece that's important in terms of an algorithm, it saves us time in that regard. But the second reason is that as we're sort of testing out the algorithm or using it, that provides more data for the algorithms to continue to learn off of. And so, the benefits of deep learning are really seen in this ability for us to kind of capture data in an unstructured format and create an artificial intelligence systems. And examples of deep learning based algorithms, your Alexa, your Siri, all of those things, ChatGPT, et cetera, they're all using deep learning at its core foundation. And I would argue that most modern AI applications are still using, are focused upon deep learning to automate in the future. So let's talk a little bit about how we sort of think about AI research and development in the context of healthcare. When I was in medical school and I was doing my postdoc, there was very commonly this sort of idea in healthcare of bench to bedside, wherein the researchers are developing research at the bench, and they're creating sort of these amazing innovations, and then they take it to the bedside in order to sort of apply that to patients. And I think in machine learning and in AI research, we have a similar sort of similar sort of model, but the model is instead something more of like calculation to clinic, in which we sort of spend this time developing these very advanced models using sort of simulated data or maybe smaller data sets. And then eventually our hope is that we'll apply it. But if we think about those two ends of the spectrum, I think that there's two different processes that we sort of think about when we evaluate them. And so if we think about the clinical side, the question that we ask ourselves is, can we leverage machine learning or machine learning techniques or deep learning techniques to improve clinical problem X? And the way that we do that is we essentially ask a good clinical question, which in my view is something that we think AI can help us change management and improve the way in which we manage patients. Second, we find and collect that appropriate data. Third, we model that clinical process. And fourth, we implement that into a clinical workflow, right? And so I think a lot of the problems that we are interestingly, like we're kind of getting to the place right now with machine learning where a lot of our interesting problems are now sort of moving into the clinical arena, where we have that good clinical question and we are finding that appropriate clinical data, because now most of our electronic medical records are available and digitized and a little bit easier to access. And then we model that clinical process and implement that within clinical practice. And so specifically, I would say that there's sort of areas that are primarily thought of when we think about the clinical application of AI. One is in the idea of prediction. Can we predict a future event using data from healthcare in the current form? Second is, can we classify? If we have the data right now, can we tell exactly what's going on at that moment? How healthy or unhealthy someone is at that exact moment? And the third is actually in automation. Is there a task that we are pretty good at right now, but is extremely time intensive and unfortunately maybe not necessarily easy to do in a clinical workflow? And can we automate that using computers and make the healthcare system more efficient? Now, on the other side, as I mentioned, is the calculation side, and this is a whole area that our group also works in, which is really more of a mathematical process. But there's a lot of different sort of pathways in which we do that. But fundamentally, what we're asking ourselves is how can we improve the way in which we model healthcare data in general so that it can be effectively applied to healthcare problems? And the way that we do that is first we develop different candidate models, different sort of models that we think would work on the data. Secondly, those candidate models essentially transform the data into an interpretable vector space or a way in which we can sort of interpret that data. Then we fine tune that model. We validate it on unseen data. So we make sure that the model is perfect and can be tested on unseen data. And then we actually do surveillance and vulnerability studies. And in the box in the corner, I've sort of cited a bunch of different sort of areas of machine learning. I think for people who are not machine learning researchers, it's not important to really understand the nuances of them, but it's important to understand that there are people who devote their entire lives to one little part of each of these little sections. And there's a lot of research to be done in all of these. There's some people whose whole career is based on algorithm design and they develop different candidate models. There's other people who are 100% focused on how we can, transform that data into an interpretable space so that we can interpret it. And that's essentially metric learning and things like that. And so similarly, I think that each of these areas in this pipeline are deep and have a lot of opportunity for advancement. Okay. So one question that commonly comes up is that there's a lot of machine learning algorithms or a lot of, sort of AI models that come across, either to you in the lay public or to researchers. And everyone asks me, well, how can I tell all these algorithms apart or all these machine learning apart? And what's the best way to kind of level set? And so the mnemonic that I teach all of our undergrad students is STOMP. And so S is basically a supervised versus an unsupervised algorithm. And so basically that tells us, do we have labeled data or do we not have labeled data? And so very frequently in healthcare, we have labeled data. We take patients for whom we know what happened and we know what their outcomes were or how they progressed. And then we basically train a model to sort of say, okay, well, this is how these people did it. Tell me how these future patients will do. But there's also unsupervised, where we say, we have a bunch of patients who potentially have like a disease like NF. Can you tell me what's similar about them and what's different? Or who are the similar patients and who aren't? And then we explore that. And that's what we call an unsupervised algorithm. The second question is sort of what type of math problem we have. And without getting into too much details, I would say that the question is more so, what are we trying to model? If you're trying to model a variable that is unboundless, like, like a age or something like that, which can have unlimited bounds, then that's a regression task. But if you're trying to classify maybe good versus bad or good responders versus bad responders or patients who live a certain amount of time versus patients who don't, that's essentially a classification problem. And again, if you're just trying to figure out, okay, well, how are these patients all similar? That's essentially a clustering problem. The third is more of an engineering thing. It's online versus batch learning. It's really primarily related to how we update the model. Online learning is essentially where you consistently update the model every time that you get new data. So as new data is coming in, you're learning from that in a continuous process. And so examples of online learning algorithms are things like Google Maps, where, as they're getting pings of people who are, in different areas of the country, traffic patterns, they update the estimated time. And so it's important for sort of dynamic models to be online learners. Whereas batch learning is what we typically do in healthcare, where we essentially get a certain amount of data, we have a model, and then we collect a little bit more data. And then once we feel like we have a decent amount of data, we update the model with that new data. And the reason why in healthcare we typically do batch learning is twofold. One is that typically our problems are not so dynamic that individual patients are going to be influencing the way in which we, the accuracy of our model. And secondly, online learning is more susceptible to sort of outlier effects of like one patient influencing the model too much. And so batch learning is a lot more stable And so it's less likely to cause us problems. And so it's a little bit more safe. And so typically in healthcare, we think about batch learning, but some instances I can think online learning as being something that's valuable. An example of a healthcare scenario in which we felt like online learning was potentially a valuable solution was during COVID, when we were tracking COVID cases and people were interested in developing algorithms that were trying to model COVID progression. We wanted to get the data as fast as possible because we thought it was a dynamic situation that was happening in real time. The third thing is a little bit more of a math thing. The M stands for model versus instance-based. And so model-based learning essentially is when you're trying to develop a function that will, be able to predict future events. And instance-based learning is essentially where you're trying to find similar patients, like a clustering algorithm. And the last thing I think is important, the P stands for predictive versus real time. And essentially, this is an important piece because predictive tasks are a lot harder for us to do. And so when we actually evaluate these in terms of looking at performance or metrics, it's important for us to, sort of lower our bar. Real-time tasks are a little bit easier for us to do because we have that data in that moment in time. And so more likely our expectation for how those algorithms actually perform is a little bit higher. And so I would say that typically when I look at a predictive algorithm, like something that is predicting whether or not a patient is going to have a good outcome 5 years down the road, I would lower my expectations in terms of how that algorithm performs. Versus if they were telling me, well, I'm going to show you an algorithm that's going to tell you if you have cancer right now, yes or no, then I expect that algorithm to perform fairly well because they have all of the important information in front of them at that moment. And so this is a good slide that can be used for reference that can sort of help basically provide you a little bit of level setting if someone's telling you about a machine learning algorithm or something of that nature. Okay, so I'm promising everybody that I'm not going to do too much math here, so I'm just going to try to give a little bit of an understanding of how we do deep learning. If we were to develop a model that was determining whether or not, each of these faces that you see here is happy or sad, it would be really easy because, it's really easy for us to tell that the frowny faces are the unhappy ones and the happy ones are the ones with the smiling faces. And if we were to develop an algorithm that could do that, it would actually be very easy for us to code that because the representation of the pixels of the smiley faces are all the same in all the smiling faces, and they're all the same in the frowny faces. But the problem is in the real world, what we see is shades of gray or edge cases. And so if I give you cases like this, it's a little bit more difficult for us to tell whether or not someone's happy or sad. And so everyone in their mind is probably determining whether or not they think someone's are happy or sad. And typically, most people are looking first at the person's their eyes and their mouth, and they're kind of putting it together. If they're grinning, then they're saying, okay, they're happy. But if their eyebrows are, crunched down, then we think that they're angry. And that's essentially what we expect these sort of deep learning algorithms to do. They and more or less break down an image into its component parts, and then based off of those component parts makes an estimate of what they think is the most likely thing that the image is supposed to be looking like. And so just like you guys are probably on your screen looking at the smiling faces and saying, oh, that's most likely a happy person, and looking at that sort of, the upper left kind of, angry eyebrows and saying, oh yeah, that's most likely an angry person. The same way the machine learning algorithm is learning those sort of components. Now, the big benefit of deep learning is not only will, when we train an algorithm, it'll learn based off of our data what these sorts of smiling faces and frowning faces are telling us, but we also can learn sort of we can also learn sort of the combinations of these that are maybe not represented in our data. So for example, instead of having maybe the angry eyebrows with the smiling face, we'll be able to do the angry eyebrows with the curly mustache. And so not only do we, if we train an algorithm that kind of learns the components of eyes and smiling faces to predict happy or sad, we similarly can figure out all of the things that are maybe not even represented in our training data, these sort of in-between cases that we don't even have in our training data set. And so another way to think about sort of deep learning algorithms in the context of vision is essentially we take pixel data from a picture. From that pixel data, the algorithm is learning lines, and from those lines, it essentially learns shapes. And from those shapes, it learns facial features, and from those facial features, it eventually learns faces. And that's essentially what we think, the broad idea of how these deep learning algorithms work. For those of you who are on the call who are, machine learning experts or applied mathematicians, obviously that's not exactly how the algorithm learns, but I think for the purposes of, most people, this is a good way to think through it. Okay, so I think the benefits of deep learning are a couple. One is that it's extremely flexible. And so there's been evidence that shows that deep learning can essentially analyze almost any type of healthcare data, whether it's genomic data, electronic health records through natural language processing, images, certain types of like proteomic, like sort of molecular data. All of those data streams have been able to be analyzed. Similarly, there's new work at the NIH about voice recordings, which is a kind of a new data stream. And so I think that it's shown to be extremely flexible. Second is on the mathematical side, it does have the ability to model any function. And so for any of you who are maybe knowledgeable about statistics, very frequently when you do traditional statistics, you have to make sure that your data fits a certain distribution in order to sort of match the assumptions that your model is making, right? Like a normal distribution or a Poisson distribution. Deep learning algorithms don't actually have any sort of distributional requirements, and that's really nice because most data in the healthcare sector doesn't actually fit into a really great distribution. And then the last thing is that a lot of people would argue that because deep learning algorithms do not require us to do a significant amount of pre-processing of the data, it can just take raw images. It doesn't require a significant amount of domain expertise. So you don't necessarily need to know all the nuances of NF as long as to train the algorithm. You can, as long as you have images that are looking at the right things and you have the right labels that are very clearly accurately sort of modeling what you want, you can train an algorithm and the algorithm will learn those pieces. And so some people would argue that less domain expertise is needed. I would argue that there's still a fair amount of domain expertise that improves the ability for us to model healthcare data. But with that said, I think that it's certainly less than what was needed before. However, there are certainly some disadvantages to these deep learning algorithms, and I think it's important to note those as well. One is that these algorithms, compared to any of the other traditional sort of machine learning algorithms or even statistical techniques, they have a large data requirement. And so we need significant amounts of data in order for us to accurately train these algorithms. The second thing is what we find is that these models actually tend to be very, very good if we give it a certain amount of training data, and they tend to overfit functions. We find that these models tend to sort of memorize data. And that's a problem because then essentially it doesn't apply as well to unseen data sources. And then the last thing is that unfortunately these models have what we call a black box sort of feature, which means that their model parameters are a little bit less interpretable. I'll talk about that in a little bit, but essentially that means that it's a little bit more difficult for us to tell exactly when a model is making a prediction, why it's making that prediction. And so it's a little bit more difficult for us to sort of second check the model in terms of its accuracy and its ability to accurately model what we want it to. Okay. So let's talk a little bit about some of the non-imaging AI success stories, because I think these are very important to think about. I would say that there's sort of three data streams that I've seen that I think that AI has been particularly good in and advancing. One is in the electronic health record. There's been a couple different data papers that have suggested that using machine learning algorithms to analyze structured healthcare data and unstructured healthcare data from the electronic health record can be valuable in terms of predicting outcomes, improving quality, and helping make our healthcare system more efficient. And so the upper left is a paper that showed that for patients who are undergoing radiation therapy, if they did NLP and some analysis of the electronic health record, they were able to sort of predict which patients would have an adverse outcome earlier and subsequently do better interventions earlier to prevent sort of an adverse outcome. And then the last one on the bottom right is an algorithm that was created by Dr. Ravi Parikh, who's at Emory University, essentially showing that they could predict which patients had a poor outcome and spur early end-of-life conversations for cancer patients by using data from the electronic health record and further improving the way in which we sort of, model and have end-of-life conversations earlier. In pathology, there's been a lot of work recently that's been done both in the diagnostic setting, but also in the molecular sort of biological or sort of pathway setting. This is just a paper that I found that essentially identified sort of pathology gliomas analyzed pathology slides to identify sort of malignant tumors versus benign tumors. And so this is a very laborious task that actually is very difficult for us to do. It's oftentimes also a very sort of a task that's very subject to inter-observer variability. And so what we know is that if we use machine learning to analyze pathology images, we can not only get an accurate estimate that improves the efficiency because it requires us to have a little bit less reliance on individual pathologists, but also it could potentially help us better analyze data so that we can see sort of unique groupings that could potentially be valuable in terms of predicting outcomes. This is an example of us doing it on brain images, which essentially was able to identify sort of areas of heterogeneity in high-grade brain tumors. And that's important in terms of developing biological understanding of sort of maybe tumor heterogeneity and figuring out which tumors are more heterogeneous and which ones are less. One area that I think is super exciting and sort of just at the initial stages is the ways in which AI can improve drug discovery. So this is a paper that was done in Nature Materials, which talks about all the different ways in which we think that AI can potentially improve the clinical drug development pathway. There's such a difficulty, especially in rare diseases like NF, where the drug development pathway is very, very promising, but it's extremely long, both in the identification of candidates, the testing of potential candidate molecules, the development of chemically stable compounds, as well as in the implementation and clinical trial phases. And so there's a lot of different ways in which people think AI can help us better predict which are the sort of candidates that we think are the most valuable for us to sort of focus our efforts on, how we can optimize sort of our experiments, or how to make our drugs in the smartest way possible. And this is an area is grossly sort of in its nascency. And I would say that it's something that we're really excited about in the long term. This is an example of one paper that found that they were able to, in a process of 46 days, identify and test a drug target for DDR1 kinase. And so they were able to basically speed up what would be a multi-year process to just 46 days, which I think was extremely interesting. So I'll talk a little bit now about some of the imaging successes that have been done in AI, and a lot of this is the work that our lab is done. So one of the biggest problems in cancer care, and NF is not any different, is that we really lack effective biomarkers. The biomarkers that we do have are inaccurate, they're expensive, they often require invasive testing, and frequently they're not very personalized. And so we feel that what would be valuable is if we use some of the imaging data that we notoriously have for almost all of our patients, both cancer, NF, et cetera. And so what we use is essentially pre-treatment imaging on cancer tumors, and then we analyze that using deep learning, and we develop personalized outcome predictions. The reasons why we think this is valuable is because, one, it's not using any data that isn't collected in routine clinical practice. Two, we feel like it's a little bit more personalized because it's really analyzing the entirety of the tumor instead of a small piece of tissue or a small amount of lab values. And three, we think that it's actually very scalable because it's something that we can integrate into the electronic medical record without any issues. And so an example of a brain tumor that we've worked at was brain metastases. So patients who have cancer in their body and then they ultimately develop brain lesions. There's a very big difficulty in terms of determining how the patients with brain lesions will do. There's kind of two tails to the curve clinically. One group is the group that we probably are expecting is sort of patients who have cancer in their brain. We're thinking that they don't have a good outcome and they have a short period of time to live. But then there's also this other group of patients on the other side of the tail, which actually do quite well with just local treatment to certain areas. And so developing an understanding of who are the patients who are going to do well and don't need maybe as aggressive treatment, and the patients who potentially are not going to do as well and who maybe would merit very aggressive treatment is a clinical challenge that we currently have. And currently, the best way that we can do that is there's a normogram that was developed that uses some clinical variables in order to sort of add up essentially all of the clinical characteristics of the patients, and it's a back of the envelope calculation that helps us predict who's going to survive and who doesn't. But it doesn't take into account any of their images or what their tumors look like. And so we felt like we could leverage machine learning to identify sort of imaging features that were shared among good patients and bad patients, and also trying to help us better improve the outcomes if we can sort of risk stratify patients based off of their images. And so this is the sort of back of the envelope calculation that is currently being used. And then when we actually first asked ourselves, can we look at machine learning to just identify imaging features that look similar to patients? And so this is an example of an unsupervised analysis where we essentially just looked at the features of that came out from the deep learning algorithm, and we clustered them using some clustering techniques. And what we see is that there are features that are associated with patients who respond to treatment and those who do not respond to treatment. And so that tells us that the images hold some information that's valuable in terms of predicting who's going to do better and who does worse. And so the idea clinically would be that these responders, patients who are in that group, then we know that the current standard of care is probably good for them. And the patients who are not responders, those are the ones who maybe we could be more aggressive for. those are potentially the patients who we should focus our clinical trial efforts on and are more likely to see a benefit in more aggressive treatment. And maybe we would be okay with a little bit more of an increased risk of side effects if they weren't able to be successful. And so this is just a good example of sort of showing that when we integrated the images with those clinical variables, we had an improved performance of our model. And we can see that we can identify these high-risk patients in a very good way. And so this helps us understand that we can sort of separate our patients and figure out the good ones versus the bad ones in a lot better and a more clinically meaningful manner. Okay, so I'll close with sort of talking about now you guys have seen some of the success stories that we think are really great with respect to AI and machine learning and all of the opportunities, but I still think that there's some barriers to the clinical implementation, and I think that's important to sort of talk about them. And so there's kind of two areas. One is this idea of surveillance and vulnerability studies, and the second is this idea of clinical implementation. And so one area that I think is an important thing is one important thing to understand is that these deep learning models actually do have a significant amount of variability and vulnerability, and they're not necessarily the most stable algorithms that are out there. And so what we found was that when we trained a machine learning algorithm to identify tumors in the brain, if we just changed a small number of pixels in those images, not enough to actually, imperceptible to the human eye, we were able to essentially change the algorithm's perception of the model from cancer to no cancer. And so this is an example of an image that is from the brain. It's a brain tumor, and our algorithm correctly identified it as cancer. And then when we did some small pixel changes, small level pixel changes, we were able to get the algorithm to predict with 99% confidence that it was not cancer. And that shows inherently how vulnerable these models are to small perturbations in pixel levels. And I think it's important to know that we need to sort of figure out ways in which we can avoid this from happening in clinical practice. The second thing is on this idea of surveillance. And so I think it's been kind of well documented in the lay press, but also in the medical literature, that AI algorithms oftentimes promulgate some of the biases that we see in our current healthcare system. And an example of that would be sort of an algorithm like this. This is an algorithm, an image that they were trying to sort of classify. And what they found was that the algorithm predicted sort of two things. One, it predicted was doctor, and the second thing it predicted was nurse, and about 50-50. And when they looked at what exactly the algorithm was sort of, well, what about the picture was telling it doctor, they found that it was highlighting the stethoscope. That was what was telling the algorithm, oh, this is probably a picture of a doctor because there was a stethoscope in it. That sort of makes sense. When they looked at what was kind of causing the algorithm to predict that there was a nurse in the picture, we found that it was highlighting the female with her long hair. And so what that essentially means is that that the machine learning algorithm thinks that, if you're a female wearing a white coat, that you more likely are a nurse and less likely a doctor. And so that's a bias that we essentially don't want. More importantly, I think that what we can find is that these sort of interpretability techniques, these ability of us to unpack and see what's going on within the model, it'll help us surveil whether or not these models are accurately predicting what we want. And so I'll give an example. This is a CT scan of a lung cancer patient. Here's their tumor right here. And we analyzed this patient to predict what their outcome was. And so this patient had a really great outcome. They were essentially cured of their cancer, and they're still alive today, doing great. Our algorithm predicted that they would, not survive more than a year. And so we had to ask ourselves, why is that the case? Was it just, the algorithm, the math wasn't good, the tumor wasn't clear enough, or something like that? And so when we actually look at what the algorithm was looking at, we found that it was picking up something that we didn't want it to. So just to give you a little background right here, the patient previously had a treatment for another disease that caused calcifications within their chest. And so these are just calcifications. These are completely benign, don't really have anything. What we found is that our algorithm was actually just reading those and saw that that was something that looked like cancer. And so they said, oh, there's a really big tumor right in the middle of their person's chest. And so this is an example of how, if I saw this with my prediction, I would know that the model was inaccurate and I wouldn't make the wrong assumption about what I was doing. And so these interpretability techniques are very important to be developed in terms of having our ability to surveil models in the future. Okay, and so let's lastly talk about clinical implementation. So one thing that I think is oftentimes lost as we develop something, any sort of technology or any sort of therapeutic, is patients' perceptions of this sort of technology and how we think patients would be reacting to us using these new technologies. And I can tell you this as a scientist myself and as a clinician, whenever something is new and fancy, I would love to use it on my patients, and probably prematurely. And so I think that in order to make sure our healthcare system is working in a health-centered way, we need to really make sure that the journey of AI is also one that we take in a patient-centered fashion. And so what we did is we actually did a national survey of patients and physicians and looked at their perceptions of artificial intelligence in healthcare. This project was funded in combination from AHRQ and the NIH. And essentially what we were asking is basically the perceptions of patients, specifically in their knowledge of AI, their optimism, and what they felt like, in terms of liability, just because we thought that was a little bit of a prickly area with respect to AI. And so when we nationally in a national representative sample, when we asked people sort of how much do you know about AI and how it can change medicine, what we saw was actually that there was a lot of geographic variability. And so what that tells us is that there's certain sort of hotbeds where patients seem to know a fair amount of AI, and there's certain other areas where patients are a little bit less knowledgeable about AI. And it's not really something that we can say is like red states and blue states or north and south. It's just that certain pockets of the country, maybe those areas, the patients are a little bit less understanding. And so I don't think we can assume that, in Connecticut, where I am at, and Dr. Buono's at, that level of knowledge is something that all of our patients across the country could potentially have about AI. The second question we asked was, for each of the following scenarios, how comfortable are you with AI doing some of those things? And we asked about chest x-rays, looking at chest x-rays, diagnosing pneumonia, telling us that you have a pneumonia, recommending an antibiotic, diagnosing you with cancer, or telling us that you have cancer. And what we found was that there's a little, so blue indicates that they're very comfortable, and red indicates that they're very uncomfortable. And what we found is that actually the comfort level with respect to AI really depends on the sort of clinical disease that we're dealing with. When it came to pneumonia and looking at chest x-rays, people were fairly comfortable overall in terms of, the AI doing a lot of that stuff. But when we were talking about cancer in any way, shape, or form, what we found is that patients were really scared at all age groups. And so specifically telling us that they want to have a doctor talk to them about cancer. And I think that this highlights that, everything isn't cookie cutter. Even though an algorithm might work in one patient population, it might not work in another patient population because the disease is different. And then the last question that we asked, one of the last questions we asked was, please tell me how concerned you are about the use of AI in medicine in each of the following, and specifically talking about confidentiality, the wrong diagnosis, spending time with your physician, and healthcare costs. And so most importantly, we found that all patients basically were concerned about inaccuracy, which I think makes a lot of sense. But I will say that one thing that we did notice is that patients who perceived their healthcare as being poor, i.e. the ones who probably are interacting with the healthcare system the most, we found that they were concerned about AI in all domains, which suggests that the patient population who's most likely to interact with the healthcare system are the most concerned, unfortunately, with healthcare and with AI in healthcare. And so that tells us that potentially our most vulnerable patients, maybe our elderly patients, for example, are the ones who we're probably the most concerned about. The next question we asked ourselves is, how do physicians and patient views change regarding AI? And specifically, we were looking at the context of liability in AI. When AI makes a mistake, who's to blame for something like this? And so when we asked the question about when medical errors result from the use of AI, who's liable? What we found was that most physicians and a significant number of patients all felt that the physician is responsible, even if AI is incorrect, because I think that that's a little bit different than if we think about drug development. So, for example, if I was to give a drug that was I was prescribed a drug that had a bad side effect, but I prescribed it within the realms of what I was supposed to, most likely, if there was an unintended side effect that occurred, the drug company is going to be liable if that was supposed to be something that was caught. With AI algorithms, most patients and even most physicians are arguably thinking that the physician is still ultimately the one responsible, even if you're using the algorithm in exactly the right way, and it just makes the wrong prediction. The other thing that I thought was interesting is that physicians are more likely to feel that a company is really doing a lot of vetting, but patients actually don't seem to think that way. And the last thing, which I thought was particularly interesting, because I think this is actually the group that's probably the most involved in actual AI regulation. Very few people thought the FDA or the government was going to be the ones who are going to be involved in or liable for sort of the problems, but they're the ones who are actually the ones who are the most likely developing the framework for evaluating AI in terms of liability. The next question we asked was, if you had a mole that was maybe cancer and the AI algorithm said, well, the mole might be cancer, so you should have a procedure to take it out. but when you do that procedure, you have an adverse event. Who's to blame for that? And they still ultimately, patients ultimately indicated that the doctor is the one to blame. So even if you make a decision and you do a procedure based off of an AI recommendation and you talk to the patient about it and disclose it, the physician still has to ultimately be the one who makes that call. And I think this is an important piece because I think that oftentimes physicians ask me like whether or not AI is going to replace doctors. Data like this suggests that AI will never replace physicians because physicians are ultimately the ones who are going to be liable, and patients ultimately hold physicians in that esteem. The last question that we had is, imagine that your hospital recently started using a computer program to diagnose some medical problems. Who do you think has checked this computer program to be safe? And I was surprised with the number of people who thought that the physician actually checked the algorithms that are being implemented by the hospital. I can tell you, working in a large healthcare system, when they implement a software, very few physicians have access to the ability to check the algorithm and make sure it works. We are, not necessarily at that level of the tools that we were given. Just like the same way that we don't check whether or not the computer screens that we're given with the electronic medical record are something that we're using. And so similarly, I think this is an example of something that I think physicians have to be very wary of using AI, because I think that there's a perception that doctors are actually looking at all of these things and understanding all of these things. More importantly, I think that a lot of people think that the company is really evaluating the AI algorithm, and certainly there's a little bit of work that's done in terms of checking it over. But I will tell you that most companies that are developing AI algorithms currently are not necessarily checking them as rigorously as I think we want them to. And so, final thoughts before I hand it over to Frank. Artificial intelligence, I think, appears to have utility in healthcare. I think that it helps model very, very heterogeneous and complicated clinical tasks like NF, and helps personalize outcomes and treatment plans. Despite that promise, I do think the relationship between AI and medicine is nascent and it's evolving. And this focus on implementation, being patient-centered, and making sure that we surveil and assess and be open about the vulnerabilities of the models is really important before we actually feel like this is 100% something that we'll be using in prime time in all of our patients. I'd like to thank everybody on the call today, as well as all the wonderful organizations that keep our lab funded. And I'll pass it over to Frank.
Awesome. Thank you so much, Sanjay. We really appreciate it. I'm going to go ahead and unspotlight you and hand things over to Frank. There we go. We are going to be running a little past our scheduled time, everyone, but hopefully you can stay on till the end. Thank you, Frank. Go ahead.
Hi, everybody. Thank you, Sanjay, for that wonderful intro of artificial intelligence. What I want to talk about is specifically using artificial intelligence within the NF population. One thing that I will put out is that I'm a psychologist, I'm a researcher. I am not skilled like Sanjay is when it comes to artificial intelligence, but I am quickly learning. So this is going to be not as mathematically as Sanjay is presented. So what I want to just talk about at least is, let's see, moving forward, why my software came to be. So in the midst of COVID, my colleague and I started the NF clinic here at Yale, and we saw a patient come into the clinic, which was 19-year-old male who was presenting with some hearing loss, NF2, and some facial droppage, but the radiological reports showed no change. As you actually can see, this is the patient's radiological reports over the course of 6 years. Now, I'm kind of giving it away with what our software showed and what the radiological report showed. And if you look at them, there is a little change with the radiological report, but there's not as significant as much as what we've showed. The issue that we found, and this is why my lab has come to be, is that we found that radiologists, it takes a lot of time to produce the imaging doing just linear measurement. So you think about it, it takes around 10 to 15 minutes for a radiologist, a seasoned radiologist, to go through it and actually read your MRI image. And typically they only look at maybe the year before, but they don't evaluate 2, 3, 4, 5 years back. and they don't see the growth over time, which is very key, especially if you have family members with NF, because some of these tumors are slow growing, and they might not grow within a standard deviation of 1 or 2 in that last year, but they might have grown largely over the course of 5 years and progressively grown, and we need to evaluate that. Um, and one of the things that we talk about, is that inconsistency, with the evaluation. And it's hard to evaluate a 3D image, which is that tumor, looking from a two-dimensional XY evaluation. And so that is one of the reasons that we started this work. So what we did, and this is also piggybacks on what Sanjay was talking about, we evaluated different radiologists and different clinicians. So we had neurologists, radiologists, and neurosurgeons at 3 different major hospitals in the Northeast. We did qualitative interviews with them. Total of 32 clinicians. This article actually just got published in Journal of Medical Internet Research yesterday or 2 days ago. And we were looking at what their thoughts were for why AI is not accepted, what is their thoughts behind it, and why can't we use it more often. Interestingly, we found that more of the individuals, clinicians, are interested in 3D imaging that actually evaluates um, tumors in multiple dimensions instead of just the regular linear measurement, which was what we found. Um, Similarly, we also wanted to understand, what is the most ideal voxel size. And when I talk about voxel size is, when you go through an MRI, or any one of your family members goes through an MRI, there are different cuts that they do. So if you do a whole body MRI, the cuts are much wider apart than if you just did a thoracic MRI in your spine, right? It's going to be much tighter. So what we wanted to evaluate is, what is the ideal cut size for doing AI software. And we determined, this article is hopefully going to be accepted in the next week or two, that a 0.5, 0.8 millimeter was the most ideal scenario for image evaluation with using artificial intelligence. So and a lot of quality of imaging did not meet that standard. You had voxel sizes ranging from very, very thin to, I mean, up to 1.0, 1.0, 4.0, in difference. So it provides a little bit of understanding of what each machine is doing is important. So I want to go into this, and want to be also be mindful of time. So as we talked about, there is a traditional model on your left, which is that linear measurement. If you see on the right, now I also will mention, and I've said this before at the CTF conference, that I am colorblind and my wife picked these colors out. So I don't blame her for the colors, but each color represents the growth of the tumor of that patient that we talked about earlier. So I'm going to play the videos. You can see a 3D representation of that vestibular schwannoma. And what you can do is we can look at the convexity, we can look at the concavity of this, and we can turn it, flip it, spin it, rotate it. Now, the problem with that is that one of those colors takes about an hour and a half to 2 hours for one of my med students to do. Takes a lot of time, right? So what we did is and I apologize, I just jumped the slides to bring us back on time as much as we can. Look at the artificial intelligence. And so we're working with Sanjay and his lab to evaluate vestibular schwannomas and other tumors. And so this is just a rendering of the AI software, which does it in 3 minutes and has a very high accuracy of growth. So what I'm going to do is I'm just going to start this play. And so it's a one button click, and in 3 minutes, you have your vestibular, both bilateral vestibular and schwannomas. You have a pons, which is that middle region. And most importantly, you have and I apologize this how small this is, but you have the size of those tumors, and we can evaluate those tumors in millimeters cubed, and so we have more finite dimension. When we compared this, and this is the most recent data that Sanjay and I have worked on together, looking at the left and the right VS models, we're having a dice score. A dice score is a way to evaluate the overall accuracy of AI software. A normal value, acceptable value is 0.7. We are exceeding with 0.91 and 0.93 respectively for the left and right vestibular schwannomas. So with that, I'm going to just give you a couple quick articles. This is one of our articles that we just pushed out from our lab. This is the background to all of our software. You can read it, which it was published a couple months ago. And then we just had an article talking about Gamma Knife and the evaluation of pre-Gamma Knife, post-Gamma Knife, and using our artificial intelligence software. With that, these are the tumors that we are working on right now: the vestibular schwannoma, acoustic neuroma, and meningioma. We have 3 tumors that we are currently working on and looking to get finished by the end of the year: plexiform, pituitary adenoma, and chordoma. With that, I'm going to stop sharing, and I will throw it back to Kate so that if there are questions, we can go through a little bit of the questions.
Thank you so much. I appreciate it. And I apologize again to everyone that we're running behind today. That was because of technical issues on the CTF side. So thank you for staying a little late and for your patience. We do have some interesting questions, and I'll admit that some of them are very much out of my own depth. So I'm excited to kind of ask and see. So one question that came through from Richard Soul asked how AI is being applied in rare diseases like NF in particular, where the challenge is the number of data points or the data sets may be very limited, given the low number of people who are affected as opposed to more common cancers, I suppose.
Yeah, so I can speak a little bit to this. So it is difficult with rare diseases to develop and use some of the cutting edge sort of AI techniques that are out there. So for example, like a lot of people ask me about like, Chat GTP and et cetera, these large language models and or the like. It'd be very difficult to do that in a rare disease context. With that said, I think that there's ways to get around that so that we can use many of the techniques that we use in AI through a couple different avenues that have been sort of evaluated. One is obviously pooling data and having groups like this come together and everyone being very invested in it. That's one thing. The second thing is that there are certain techniques mathematically that you can do to enrich the data. A common technique that we use in our lab is called data augmentation. If you think about an image, let's say we had a classifier of a dog and it was looking to the left, we could flip that image and make it a dog that's looking to the right by just turning the image. And then essentially our data points become 2. And we've trained the algorithm not only to look at left-sided dogs, but also right-sided dogs. And so data augmentation is a very common technique that we do to sort of enrich data sets in computer vision models. The other thing that I would say is that on the mathematical side, there are certain techniques that are a little bit more focused on rare events and sort of events that are a little bit more unlikely. And so for rare tumors, I think that that's something that a lot of people think about. It's primarily work that has been pioneered by the credit card industry, believe it or not, because it's like an anomaly detection. But there's certain techniques that are out there that people have sort of used. I don't know if many people have used it in the context of sort of rare tumors, but certainly in like the diagnostic setting where we think of like maybe everyone who gets a mammogram, there's only maybe 10% of the patients, or maybe less than that, who actually have cancer. That's a little bit more where people have used sort of this anomaly detection sort of techniques, and there's different ways in which we can do that. But I think that those are kind of the 3 ways that I think of us addressing the data gap. The other things that are sort of in the pike that people think about, one is that we can make our models more efficient so that they require less data. There's a lot of people who are interested in this idea of sort of data pruning or pruning our models so that they're smaller and they require less data. And so that's something that is sort of a little bit in the early stages, but something that's very promising as well.
Wonderful. Thank you so much. So another question that I'm also very curious about is that, Frank, when you talk about the AI imaging or using AI to look at the imaging and understand the tumors that are being seen for measurement and volumetric purposes, is this something that is currently available in other locations, or this is unique to your lab because you're doing this kind of ongoing research?
That's a great question. I think there are a couple labs that are out there that are doing things like this. But it's dependent on certain softwares and what is out there. I mean, I can tell you that the work that Sanjay and I have been doing together for the last year is pretty specific in that we are the only ones that are doing a fully AI model with 3D modeling of the tumor. There is other companies, there are other softwares out there that are doing things which are close to it, but not like what we're doing.
Awesome. Maybe just one more question, because I think you were starting to mention it sort of at the end of what you were saying, Frank, which was that right now, obviously, the paper you're about to publish, it was looking at vestibular schwannomas, and it looks like you are actively pursuing using this technology to start measuring other types of tumors that exist in the other forms of NF as well. Is that correct?
Absolutely. Yeah. So Sanjay and I have a grant that we will be submitting relatively shortly for plexiform. And we have a shared agreement with multiple different universities we already have access to 250 some plexiform neurofibromas. So we will be starting that project relatively shortly and hopefully have some good news for by the next conference and present that data then.
It's fantastic. So in the interest of time, I am going to go ahead and end our webinar for the day. There were other questions that came through, and so I just want to let everybody know that I have those questions and I will be going through them, and I know how to get a hold of both Frank and Sanjay and can do creating some additional resources. You can always reach out to me via email. We'll drop my email into the chat here, and I'm happy to follow up on anything you learned today. And if it's outside of my ability to answer, I'll figure it out with you. I know who to contact. So a big thank you again to both Frank and Sanjay for being here today. Just incredible to start to try to understand some of this technology. And really want to say I appreciate the discussion around the comfort that patients have or don't have with the concepts of machine learning and AI. I think it's important that we continue to provide these educational opportunities to try to increase that and help us to be asking the right questions and understanding, how our data might be used or how AI might actually improve the lives of people living with NF. So thank you to both of you. This NF Knowledge series is presented every month. We'll be back in August and September. So be looking for in your email. Hopefully you're subscribed to the CTF newsletter, which is a great way to make sure you find out when these webinars are happening and what the topics are going to be. So all of that information on how you can get subscribed is being dropped into the chat right now, as well as my email address so that you can reach out to me. So again, a big thank you to everyone for being here with us today, and to our speakers, and for everyone's patience with us getting started a little bit late. So thank you again, and have a wonderful rest of your day.